Greetings from Austin, Texas. I'm Victoria DeFrancesco Soto, the Assistant Dean for Civic Engagement at the LBJ School of Public Affairs. This year, we turn 50. 50 years of fulfilling President Johnson's charge that he gave to us at the inauguration of the School of producing thinkers and doers to engage in the public arena. In commemorating our anniversary, we've launched this series in the arena where we bring together world-renowned experts and frontline stakeholders to engage and inform folks in the most pressing issues of the day. And today that issue is the coronavirus. For those of us who have been fortunate enough to not have fallen ill, we are still severely impacted by the social distancing policies as part of addressing the coronavirus. Policies informed by statistical modeling and network epidemiology. To understand these models and the larger science, the interface between science and public policy, we turn to one of the nation's top experts in this field, someone whose research is informing present day the CDC, the White House, global health associations, state and local governments. It is my immense pleasure to introduce today Dr. Lauren Ancel Meyers. Dr. Ancel Meyers is the Cooley Centennial Professor of Integrative Biology in Statistics and Data Sciences here at the University of Texas at Austin. She was trained as a mathematical biologist at Harvard and Stanford and has been a pioneer in the field of network epidemiology and the application of machine learning to improve outbreak detection, forecast, and control. She leads an interdisciplinary team in uncovering the social and biological drivers of epidemics and building practical tools for the CDC and other global health agencies to track and mitigate viral threats, including COVID-19, pandemic influenza, Ebola, HIV, and Zika. Before we begin, however, I want to let everybody know that this session will be up and available on demand on our website, LBJ in the Arena, later this evening, in addition to a deeper dive with all of the research that Dr. Ancel Meyers and her team have been developing addressing these issues. Also, please feel free to submit any questions you may have to me on the chat, and we will get to them at the end of the session. Without further ado, let me thank Dr. Ancel Meyers for joining us and hand it off to you.
Thank you so much, Victoria. Thanks for that nice introduction and especially for this invitation. I truly have never felt as in the arena as I do today, and I'm going to spend a few minutes telling you how we ended up doing analysis that is so central to policymaking today, and a little bit, just give you a little tour of some of the activities we've been up to in the last few weeks. I'm going to share my screen, some slides, if I can find them. Okay. Are you able to see the slides?
Yes.
Okay, great. Okay, so as background, I have been building models of epidemics and pandemics for about 20 years. And in the aftermath of the 2009 H1N1 pandemic in Texas, we worked very closely with the state to build a set of decision support tools, including a model that simulated the next pandemic through Texas, where the user could plug and play with different scenarios and see how vaccination campaigns and different sorts of interventions might impact the spread of the disease. Fast forward to about a year ago, based on the work I did for Texas, we started a contract with the CDC to build a national scale version of the model that would be part of a national modeling resource. That would be one of several models that the national government and researchers around the country and the world could use to prepare for the next pandemic and help support decisions in real time. Well, we were in the middle of a one-year contract along with 4 other modeling teams around the country and around the world when COVID-19 started to spread. Our model was probably about 90% of the way developed, and we and the other research groups that were involved in this flu code project very rapidly recalibrated our models, adjusted them to reflect COVID-19 to the best of our ability. And so we have used this model. We've developed many other models by now and done a number of different projects to get a basic handle on how this disease is spreading around the globe to support decision-making at multiple scales. So we've been supporting the CDC. We have weekly calls with them along with modelers from around the world. And we have also gotten requests from the White House Coronavirus Task Force to do analyses using the kind of model I just briefly described. We have worked very closely with city leaders in Austin. In fact, that is our closest collaboration by far. We are talking to them on a daily basis to do modeling, to provide situational awareness, understand what's happening here in Austin, how our social distancing efforts are or are not impacting spread, and also conducting similar analyses to support decision-making throughout Texas. And we are also trying to reach out to the public to raise public awareness about what the science tells us, what the data tell us, including instead of publishing one of our models in a manuscript, we actually published it on the front page of the New York Times. It was an analysis that estimated for every county in the country, what is the likelihood that there is an ongoing epidemic today of COVID-19 based on the possibly very few cases that have been reported so far. So in my few minutes, I want to give you a somewhat whirlwind tour of 4 different projects. The first 3 I'm going to talk about very briefly, and the last one I want to spend a little bit more time on. It is some analyses that we presented yesterday to the City Council of Austin that is informing the way people are starting to think about our options going forward in the next few weeks and months. So the first 2 were studies that we did really very early in January and February to get basic insight into how this virus was spreading in China and what the risks might be for this before it was declared a global pandemic for broader transmission around the globe. And these 2 studies I'm going to talk about briefly were really oh no moments. They were moments when we were like, wow, this virus is something that it's going to be an enormous challenge in the weeks, the months ahead. So the first study was really something we initiated within days of hearing in the national news, along with everyone else, that there was some anomalous virus that was spreading in Wuhan. We immediately obtained mobility data. So the graphs you see here are based on the GPS traces of millions of cell phones in China. What you see here is the typical travel in and out of Wuhan during the same period when coronavirus was first spreading in Wuhan or first reported in Wuhan. The blue line is how many people are leaving Wuhan every single day. The red line is how many people are returning every day. You see this sort of spike right here in the middle that peaks out at 1 million people leaving on a Friday, coming back on a Monday. Wuhan is a big college town. This is like a long holiday weekend. The kids leave, they go home, come back. We use this data as well as information about where the first cases of COVID-19 had arrived outside of China in January to estimate how much how quickly the disease was spreading in Wuhan and how much had already probably spread out of Wuhan to other cities around China and around the world prior to the January 23rd lockdown of Wuhan. And what we discovered was that this virus was spreading much faster than anyone anticipated at the time, that by January 22nd, when Wuhan had only reported 425 cases, there were probably at least 10,000, if not more cases in Wuhan already infected. Also, it was clearly too late. Our estimates were that there were hundreds of other cities in China that had already had cases imported to those cities, and likely there were outbreaks already underway. And all of this has been validated by the very rapid spread of COVID-19 around the globe. The second study we did that was really an oh no moment for us was a study we did based on case reports that we gathered by scraping data from 18 different websites of provincial health departments that covered about 93 Chinese cities. So what did the data look like? Well, the data were on cases, and what the data told us was that there was a primary case and a secondary case. A primary case was sort of a person who first got infected, and the secondary case was the person they infected. The data we had, or we were able to estimate, was the date at which the first case developed symptoms and the date at which the second case developed symptoms. And we call that period between the index case developing symptoms and the second case developing symptoms the serial interval. We wanted to estimate what the duration of serial interval is because that tells us, or told us, and it would give us a sense of how quickly this virus was going to be spreading throughout China and in the rest of the world once it arrived in other countries. And what we found by looking at about 450 case reports where we had this kind of data were a few very important things. Number one, and this is just a distribution of serial intervals, over 450 cases, this disease was spreading very quickly. It had a serial interval of around 4 or 5 days, which was about half the serial interval of SARS. And at the time, we were assuming that this virus would spread about as quickly as SARS. So this virus is much speedier than SARS, that there was pre-symptomatic spread, meaning the second case was actually developing symptoms before the first case. So that was the real oh no moment, that this thing was a silent spreader, that even before someone feels sick, they can be contagious. And then at the far end, some individuals are not spreading disease, are not infecting others until weeks after they first develop symptoms, which means that we have to isolate people for quite a long time to ensure they don't spread disease. So those were the two oh no moments. And now I'm going to fast forward to some of the recent stuff that we've published, some of the analyses we've done. So the next thing I want to mention is forecasting. And you have probably, or you may have heard in the news about the IHME model. This is a model that was developed out of Washington State, and it has been cited by the White House, by other decision makers as sort of guiding their perspective on the risks across the country. What this website provides is for every state, a projection of how many people will be dying in the coming weeks, in the coming months from COVID-19. So this model has come under a lot of criticism for a variety of reasons. Nonetheless, it has provided, I think, a service in helping people think about what are some things that are important to project, how can we just think about what the shape of epidemics is going to look like under lockdowns, et cetera. So there's a real value to this, but there's also some limitations. So based on what we felt were some limitations or areas for improvement, we built our own version of the model. The two key differences between our model and the IHME model are that number one, we correct what we believe is sort of a statistical error. If you look at the curve on the left, their red curve, you see these error bars that get smaller and smaller as you go further into the future. So that just doesn't make sense. We know from weather forecasting, the farther we look into the future, the more uncertainty there is about what's to come. It's very hard to project out till June or July, yet their forecasts project with certainty that there are going to be no deaths at that point in time for Texas. So we correct this, we more correctly account for uncertainty, but more importantly, the original model looked to data from China and looked to data from Italy and Europe to project what would happen in the United States once we enacted social distancing. And it assumes that deaths and infections will dissipate in the exact same way that we've seen elsewhere. Instead of assuming that our experience with COVID-19 will mirror what's happened elsewhere, we actually base our projections on local data. We look at the cell phone GPS traces of millions of people to estimate how much social distancing actually is changing behavior, how much more people are actually staying at home and abstaining from going out in public and meeting in different places. So we now have our projections online. You can look at them at a state level, a national level, and even a city level for the 99 largest metropolitan areas in Texas. So finally, I want to talk about an analysis that we were actually completing as I speak, but these are some sort of preliminary results that help us to conceptualize the major challenge that many of our policymakers, many of our city and state and national leaders are struggling with now, which is how to relax social distancing as if we must, right? There's all sorts of economic and political and societal pressures to allow people to go back to work, to allow people to get back to life as normal. However, that comes with an enormous risk that as we get back to work, we will fuel more transmission that will end up leading to catastrophic surges in hospitalizations, deaths, et cetera. So, but we are in a situation where there's a lot of pressure. We may not even have a choice. It may be that regardless of the policies, people are going to do what people are going to do. They are growing weary of staying at home. And so what do we do? What is the best way to sort of mitigate, given that we may not have a choice in how much social distancing we can actually enforce? So I'm going to go through 4 graphs that are going to kind of build up to just hopefully an understanding of where we are and what the options are in the next few weeks and months. So let's start with one sort of extreme scenario. Let's imagine actually there is public willingness. There is enough testing, tracing, and isolation. We managed to really enforce safety and health standards in workplaces so that even if we go out, we're still able to reduce the risk of transmission by a lot. So imagine that we are able to indefinitely reduce transmission by 90%. Well, then this is what we would expect in Austin. What you see here is a graph showing all the way through September of 2021. The y-axis, I'm going to show you both hospitalizations and deaths. So hospitalizations is that little red blip on the bottom. You can hardly see it. That's actually where that little peak is where we are today. That red line across the middle is what we've estimated to be our surge capacity for COVID-19 in Austin, Texas. And you can't even see it, but there's a little black line along the bottom, which says that if we manage to sustain this kind of social distancing, then we will see maybe under 100 deaths. And if we zoom in, that little blip is where we are now. If you can see, there's a bunch of black dots there. That's actually our hospitalization data for the 5-county MSA for Austin metropolitan area. And you can see that our projections, our model is fitted to those data, and the projections from our model, pretty closely match what we've actually seen from hospitalizations recently. Let's go to the other extreme. So this is that let me mention one other thing. If we are indefinitely sheltering in place, that means we're basically in a 1.5 to 2 year lockdown, or 1.5 year lockdown, and schools are probably going to have to be closed, or really kind of in sort of semi-sheltering mode for the duration. So this could come with a pretty substantial economic and societal cost. So let's think about the other extreme. Let's imagine that starting May 1st, as things start to relax, things relax a lot, that we are almost go back to life as normal, but we're still taking measures so that we're not back to baseline transmission, but we are only able to reduce transmission by 40%, wearing face masks, keeping distance, et cetera. So here's a scenario where we're sort of indefinitely relaxing to the point that transmission isn't all the way rebounded, it's 40% of normal. 40% lower than normal. Okay, so then this is what it's gonna look like. We had that stay home, work safe period over there on the left that lasted until May 1st. You can see that little blip at the bottom, that's the current hospitalization curve. If we relax to only a 40% reduction in transmission, we would expect a huge wave of hospitalizations in red that far exceeds our capacity by midsummer and stays above capacity for about 3 months. So above capacity means the kinds of pictures you've seen from Italy and the stories you've heard from New York, where we simply don't have hospital beds, we don't have nurses and doctors to care for patients sick with COVID-19 and other ailments that bring people to hospitals. So that is absolutely, that is a non-negotiable. Nobody wants that, no matter how much they want us to come back to economic life. So what else are we seeing here? The projection of just COVID-19 deaths without accounting for the excess surge is 2,900 deaths, but given that during that July to September period where we're over capacity, we would expect there to be quite a much higher mortality rate for COVID-19 patients and other patients that are in hospitals. This would only require the initial 38 days of lockdown that we're sort of almost at the end of, and schools could open in this period, but it would come with catastrophic surge in healthcare needs. Okay, so the first scenario is possibly infeasible. We may not be able to implement measures, take steps that can really contain, suppress transmission for the next 18 months to that level. And this option is probably unacceptable. I don't think there is anybody who would say it's worth whatever the costs are to end up in a situation where we are going to exceed our hospital capacity by so much. So what we've done is we've done an analysis where we have used optimization, stochastic optimization, using our epidemiological models to figure out what is the best strategy for preventing a catastrophic surge in hospitalizations that exceeds our capacity while still minimizing the number of days that we are in lockdown, that we're back under the stay home, work safe order, okay? And what I'm about to show you is just one plausible scenario. We can run these kinds of optimizations with different kinds of inputs. But in this scenario, what we're gonna assume is that when we relax starting March 1st or May 1st, we are gonna go into this regime where people are taking some measures that only reduce transmission by about 40%. But if things look really threatening, we can implement short-term lockdowns that reduce transmission back down to that 90% level, but we wanna minimize the time we're in that lockdown. So here's the optimal strategy for that scenario. So, and I'll tell you what I'm not giving you the details of it, but the way the strategy is implemented is that we are monitoring every day how many new admits there are to the hospital, how many new people enter the hospital for COVID-19, and how many total people are being cared for in the hospitals for COVID-19. And when we hit a certain threshold, in this case, the optimal threshold is about 80 new admissions, When we hit 80 new admissions per day, we're going to start the lockdown. And when we come back down below 80 new admissions per day, we're going to release the lockdown. And that turns out to be the optimized strategy that simultaneously ensures that hospitalizations never exceed capacity and minimizes the number of days that we are in lockdown. So including the original period, this suggests if we implement this period, this lockdown strategy, we estimate that we'll be in lockdown for a total of about 135 days. It's going to be a late summer 3-month lockdown that's released about a month after schools were scheduled to start. So it might mean that kids could actually go back to school in September, but it's a month later after the original scheduled start date. This lockdown would succeed in averting that first huge major wave we saw in the last graph. We would actually expect there to be a third wave that peaks sometime around November, December, but it will be self-limiting because we're approaching herd immunity. And unfortunately, under the scenario, because we're not trying to minimize deaths, we're not trying to minimize hospitalizations, we're just trying to prevent a surge in capacity, we still project that there would be about 3,000 deaths in the Austin metropolitan area in the next 18 months. And for comparison, there's an estimated about 10,000 deaths for all causes in the metropolitan area annually. So I just want to emphasize before I go on to my final figure is this is why we have the title. We introduce this as how to relax social distancing if you must, right? Nobody wants 3,000 people to die, but if we are really forced into a scenario where we can only lock down for a very short period of time and there's not a public willingness to really try to social distance for a prolonged period of time, this is the best solution for minimizing the period of the lockdown and preventing a catastrophic surge in hospitalizations. This is probably my most important slide. In all three of those previous slides, I didn't mention it, but we assumed that during the period of relaxation or lockdown, that we are doing a very good job of cocooning our high-risk populations. What does that mean? Well, healthy young adults and kids are able to go out and do take precautions and interact with people. Older people and younger people with high-risk conditions are still reducing their probability of infection by 95%. So that is what I mean by cocooning, sheltering those high-risk populations so that their risk of infection is 95% reduced. If we aren't able to do that, if our vulnerable populations end up being exposed, if we reduce cocooning from 95% efficacy just to 80% efficacy, the projections are so much bleaker. So first of all, if we assume that we're only able to achieve 80% cocooning of those high-risk populations, and we rerun the optimization, our optimal strategy tells us that we need to trigger closures much earlier, because with the exposure of these vulnerable populations, we are going to see many more hospitalizations and many more deaths. So our best case scenario, our best strategy for preventing surges in hospitalizations while minimizing the days of lockdown, so here's our hospitalizations again, here's our capacity, requires almost a year of lockdown. It's 4 different periods of lockdown, each lasting 1 to many months. And we end up still having almost double or more than double the expected mortality because of the exposure of the vulnerable populations in this scenario. So this is arguably one of the most important things that we need to be thinking about is how can we protect our vulnerable populations? How can we ensure that this virus doesn't get to nursing homes? It's not about bringing in a strike force after the nursing homes have already been exposed. It's how do you staff now so that you limit the number of residents that each caregiver interacts with on a daily basis? How do you incentivize people to stay home from work if they're sick? How do you incentivize members of our workforce who have high-risk conditions, who may not be able to afford to miss a day of work, to stay home and protect themselves? And there's been a lot of discussion about, is May 1st too early? Should we wait till June 1st and July 1st? Well, epidemiologically, as far as what's going to happen, waiting is just going to prolong sort of delay the inevitable. We're still going to have cases rise, whether we wait till June or July. But what delaying does is it buys us time to protect these populations, to provision our cities so that we can ramp up testing and tracing and isolation. So that is the best thing that delaying can do. It can just give us a little more time, a little more capacity to prepare, to protect, and to mitigate transmission when it does start to increase. So with that, let me just mention that my little lab has expanded into a consortium of dozens of people who meet daily on Zoom. If any of you are working on COVID-19, would like to collaborate with us, would like to talk to us, or interested in the consortium, please let me know. And with that, I'll just acknowledge a few of the many people who've contributed to this important work and some of the funding agencies. Thank you.
Thanks, Lauren. So you just mentioned testing, tracing, and isolation. And so could you give us a sense of how that factors into these models? Say in the next couple of weeks, we get increased capacity for a lot more testing. We're able to hire a lot more folks to do the tracing and then hence effectively isolate folks, as we've seen in other countries. How does that change your predictive models? And another question related to that is, what about folks who have already been infected, and how do they factor in? I know the WHO recently said that there's no guarantee that somebody that has been infected is immune from it. So the idea of immunity passports is not really a good one and not one that's suggested for government. So how are you factoring in these other elements into the models?
Yeah, so testing for active infection, the first kind of test we're talking about, it can do two things that are incredibly valuable. So first, if we are testing in a way that we feel like we are really effectively sampling our population, that will just give us better situational awareness. So we can know in real time how quickly is this spreading, and we can take action to respond to increasing transmission and maybe relax things if it looks like people are really taking measures to prevent transmission. So that's situational awareness, surveillance. The other thing that testing can be critically important to is actually mitigating the spread of the disease. But that requires actually three things. So you hear a lot about testing and contact tracing, right? If somebody has symptoms or we think they've been exposed, we go test them. If they're positive, we quickly try to find out everyone who they could have come in contact with, track down those people, test them. That has to happen very, very quickly. But the third prong of that is isolation, right? Mm-hmm. If you do identify somebody who is possibly or probably or confirmed infected, how do we ensure that they actually self-isolate, that they quarantine themselves? For some of us, that's going to be easy. We stay at home, we avoid contact. For people in group living situations, for people who feel compelled to go to work, it's very difficult to ensure that people isolate themselves. And in countries where we've heard that this has been, and cities where we've heard this has been effective, like in Hong Kong, the third prong, isolation, they're actually taking positive people and basically putting them in hospitals to ensure that they do not expose other people. So for that, if we are able to ramp up testing, tracing, so both happen very quickly, in addition to isolation, then that can be what contributes to the overall reduction in transmission. Then instead of maybe being at 40% reduction in transmission with effective testing, tracing, and isolation, we can actually reduce transmission to 80%, by 80%. Mm-hmm. So that can be really critical. And then with respect to the other kind of testing, so this is antibody testing or serological testing that is used to, after the fact, test to see whether somebody has been exposed to the virus, has been infected with the virus, see if there's evidence from their immune system that they've responded to the virus. What you said is correct. Like, based on what we know now about the tests, there's questionable reliability, right? So the idea that you can get a test, if you come positive, you've been infected and you're never going to be infected again, we're not there yet. We don't know. There's questionable reliability about these tests, and even if you do test positive, even if the test says that you were exposed sometime in the past, we don't know if that exposure was immunizing. We don't know if that will prevent you from becoming infected in the future.
Yeah. So Lauren, I'm so struck by the variance in the different probabilities based on the aggregate United States. And then when you can click on an individual states, the differences between the states, and then the differences within the states. So if you look at different metropolitan regions, and I invite everybody to look at these projections, they are fascinating. So, based on that, I wanted to ask you, in terms of how your research has been understood at these various levels of government, because you were talking to the various levels of government and helping inform policy, but we see such disparate projections. How do you see this jigsaw puzzle coming together?
Yeah. So if, I think you're referring to some of the mortality projections for the cities, the states, the US.
Yeah.
So in some ways they look really different, right? In some places it's clearly peaking and we're on the descent. And in other places it looks like it's flat, but there's a ton of uncertainty and it could increase in the future. When I look at what's happening around the world and when I look at what's happening around cities in the United States, it's all very consistent with our kind of basic scientific premises of how these epidemics spread. We see the same kinds of curves time and time again, not just with COVID-19, but with influenza and all the other viruses we've been studying for a century. And so in some ways, it's all very consistent. And when you see discrepancies, it can be because of a number of different things. One is just, when did outbreaks in cities begin? Some cities were unfortunate to have early importations and experience very rapid transmission. And so you saw cases, you saw hospitalizations, you saw deaths start climbing earlier than in other places that didn't have importations quite as early. So part of it is just about the timing of the introduction. Importantly, a huge part of how much the hospitalizations and deaths surged and how quickly was also about how rapidly policymakers enacted shelter-in-place orders. There's a very strong signal of that in the data as we look around the United States and around the world. These very catastrophic outbreaks tend to be correlated with delayed interventions, and places like Austin, which took very early and effective action, fortunately have hardly seen the kinds of surges that we've seen in New York and Italy. And so the timing and the extent of the intervention also explains some of the differences. And then when you look specifically at our forecasts and you compare the cities and the states, you'll have a state that looks like it's far past its peak, but then when you look at some of the major metropolitan areas within that state, one will look like it's peaked and one will look like, well, it still could be expanding. A lot of that is really about uncertainty and not about actual differences in what's going on the ground. One of the difficulties with making projections from death data is that there's far more disease than there is death, so we're only seeing a sliver of how much disease there is in a population, and there's a long delay between when the transmission event occurred and if somebody unfortunately ends up dying, when they die, right? It's 3 or 4 weeks between a person becoming infected and then dying on average. And so that means that even if there has been a lot of transmission and it's already subsiding in a city, we may not be able to detect that in the data until a month after the fact. And so in cities where there just hasn't been that much transmission, the signal is going to be pretty small and it's going to be delayed. But the reason we're looking at deaths, despite this delay, instead of hospitalizations or case counts, is because it's really the only reliable data we can get from all the cities and all the counties around the country. There's confirmed cases are reported all over the place, but testing is very idiosyncratic and very hard to map directly to the amount of transmission that's happening. And hospitalization, that's actually in some ways the gold standard of the kind of data that we want to use to fit our models and make forecasts. And that is what we're using here in Austin. But we are really in a unique situation because of the sort of unprecedented collaboration between the researchers, the city leaders, the folks that are running our hospitals and on the front line, where there's incredible data sharing and daily conversations so that we are orienting our analysis to the things that are most useful, and they're providing us data so that our models are as reliable as possible. But as I talk to my colleagues, other researchers around the country who are trying to do similar kinds of analyses for different states, different cities, we realize we're very fortunate to have the kind of data that we're able to see on a daily basis in Austin.
So Lauren, would it be a stretch to say that the relationship that you have with local city leaders, policymakers, is the exception rather than the rule, or is it a little bit more varied in terms of where you're looking at in terms of localities in the United States?
It's hard to know how many cities have local modelers or non-local modelers that they're consulting, on a daily basis. I do know once a week I'm on a call that's organized by the CDC where there's dozens of other modelers, and I get the sense that there are not a lot of other modeling groups that have established the same kind of relationships with local or state policymakers, but certainly there are probably some that are doing a good job.
So I've gotten a lot of questions, as you can imagine, about Texas, the statewide, we saw that tomorrow, a number of the restrictions that were put into place are going to be relaxed. Establishments such as restaurants and malls will be allowed to open at 25% capacity. What does that look like in terms of, kind of some of the graphs you were showing us earlier, Lauren, in terms of how much are we going to see hospitalizations and death rates under that 25% capacity easing in from Governor Abbott's orders?
Yeah. I mean, the short answer is we have no idea. It is really hard to know how people are going to behave in Austin and other cities, right? We could, sort of officially relax things, allow people to go to work, allow people to go to these public places, yet people either don't or limit the amount of visits to public places each week. And when they're there, they take extreme precautions. They wear face coverings, they keep their distance. Importantly, they don't go out if they even have the slightest sniffle or cough if they wake up in the morning, right? All these things are little things we can do that might mean that we continue to reduce transmission by 80 or 90%. However, if people are growing weary, they're sort of more lax. If if the loosening of the restrictions means that people are actually going out sort of carelessly and coming in contact and not thinking about, the consequences for them, their families and their neighbors, et cetera, then this loosening could actually dramatically increase the rate of transmission in Austin and in other cities. And because of the limited data that we have, I mean, even with hospitalizations, which we have great data, there's a lag between when people are infected and if they're going to end up being hospitalized. There's also a lag to when they get hospitalized. So we have a 10-day to 2-week delay between when we would maybe first see a sign that transmission rates are increasing. So if we want to keep track of it, we may not know that things have gotten bad until 3 or 4 weeks after transmission starts increasing. So we don't know. The hope is that that the public will continue to take precautions, that will take steps to kind of protect themselves and protect their neighbors as the policies start to relax.
So one more question before I open it up to Q&A, but this past weekend, Lauren, you were featured in The Statesman and highlighting that you've been preparing for this fight for decades. So my question is, do you feel that public policy leaders have been preparing for this fight of a potential outbreak? And if not, what should we be doing? And I'm thinking of my students, I'm thinking of the LBJ school. What can we be doing to prepare our policymakers for fights like these, which regrettably will likely still occur in the future?
Yeah, that's a hard question. I mean, they're in my little world of people who model pandemics and the people that we work with at CDC and state agencies, we've been thinking about this for, a couple decades at least. Really, I think the sort of field of pandemic preparedness was sort of launched around 1997 with the emergence of influenza H5N1, the avian flu, as kind of a real potential threat that could ultimately spread around the globe and cause the kind of mortality that we're seeing today for COVID-19. So in some respects, there's been a small group of people around the world who have been thinking about this, who have been building models and making plans. However, it's difficult. Like, public health is not a highly resourced operation in the United States, right? I mean, I mentioned very early on in my talk that we had built a pandemic flu toolkit for the state of Texas in the aftermath of the 2009 pandemic. This is an online tool. It has, for example, an optimization tool that says if you have to very quickly distribute a medical countermeasure like antivirals to everybody in the state, and in particular, you want to make sure it reaches our at-risk underinsured populations that won't be able to maybe get access to healthcare or medicines through normal kind of medical or commercial channels, which specific pharmacies and which specific zip codes around the state should we set up distribution points? Okay, I mean, and there's 3 or 4 or 5 different tools that are like this. And at the time, it was really like a concerted effort. Let's learn lessons from 2009, what went well, what didn't go well, what kinds of analyses and tools will be helpful if we ever face a situation like that in the future. And it was really forward thinking at the time. However, those tools, they've been online since 2013. The people in the state who contracted them are no longer working at the state, and they've sort of I think that, and there was no ongoing training or maintenance of these tools. And so there are kind of moments in time where there's sort of a concerted effort to do this kind of planning. And then Ebola happens or Zika happens, and we lose track of, and it's super high priority, and absolutely that's where our resources need to go, if we have limited resources. But we sort of have lacked a continual investment and like sustained development of tools, of plans, of policies, of approaches that would have been very useful today. So there are things that are incredibly useful, but there are also, and that we've already developed over the last 20 years that we're redeploying for COVID-19 that's providing immediate insight. But there are probably 10 times as many things that we are just scrambling to figure out and to build the right model and to make the right decision. So I think the answer to how can the people in this audience, and how can the world in general do a better job of planning for the next one and hopefully preventing the next one, is I think just taking time in the aftermath of this to really learn about, to think about what happened here, and to put resources in place, put ideas in place that we sustain and kind of are going to be ready to be deployed the next time a threat emerges in China or wherever.
So I have one question about K through 12 schools. There's considerable concern over opening public K through 12 schools in the fall. Do you have any data on the spread of corona at schools? And Lauren is the mom of a kindergartner and a first grader. I have this concern because I know how in close proximity the kiddos are, and they're not washing their hands as much as adults are, and they don't have that capacity that, say, adults to social distance. So I think this for me is also a concern that I share. What are your thoughts?
Yeah, so we know that kids spread viruses very quickly. In fact, in a study we did a couple of years ago where we were looking at, we were modeling the spread of common cold viruses. So we know a lot about flu because it's a very severe virus and we conduct surveillance for it. We don't conduct surveillance for run-of-the-mill viruses that cause our sniffles and our mild fevers and stuff. And in this study, we estimated that children get common cold viruses about 7 times per year, and adults get about 2 times per year. So we know that they are, they infect each other readily. And we also know when we look at more detailed surveillance data for influenza, every year, that they are also kind of the leading wave of transmission. It spreads in schools and then they bring it home, and then, maybe it eventually gets to, older extended family members and other members of the community. So, epidemiologically, children are really important vectors, right? I mean, they spread to each other, they bring it home. However, with COVID-19, the data on pediatric infections is just extremely scarce. So what we believe is that children probably are infected, maybe as easily or not as adults, but that they mostly experience very mild or even asymptomatic infections. Now, there certainly have been children who end up in the hospitals with COVID-19, but it's pretty rare. So, we believe that if kids go back to school and COVID-19 is still circulating in communities, that they will probably that having kids go back to school probably will amplify transmission, unless measures are taken to kind of prevent transmission in schools. And that also it's going to be that it could also it's not only the children spreading disease to children, but it's then bringing it home and possibly starting chains of transmission that ends up reaching sort of more distant members of our community. So I think the risk is real, and if schools are going to open, we have to understand what that will likely mean in terms of amplifying transmission and how it might increase hospitalizations, and whether it might move us precariously close to our surge capacity. In the graphs that I showed earlier, there was one where it was sort of the optimal strategy, if you have to relax social distancing, predicted that it would sort of run, the epidemic in Austin might run its course, by about September, which means maybe kids could go back to school later in the fall, and without a tremendous risk of amplifying transmission because we'd already reached herd immunity. But that is really kind of just one particular plausible scenario where we assume we are able to do incredibly targeted shelter-in-place orders, right? So I'm fairly pessimistic that come fall, we really will have sort of eradicated the local risk to the point where there will be no risk if we or no increased risk if we let kids go back to school.
So Lauren, I have a question about Sweden's strategy. It seems to be a best practices. Do you have any thoughts of that? Looking also globally to best practices in mitigating the risks of the coronavirus.
Yeah, it's very interesting, and I don't have any firsthand knowledge of what's really going on in Sweden. I just been reading about it in the paper, and I think it's not entirely clear what the true burden of disease in Sweden is, what exactly they did, what the differences are between individual behavior in Sweden when you relax social distancing and what it would look like here if we relax social distancing. And it's a different culture, different way of life. So I think it's very hard at this point to kind of point to, this is what they did, this is how we could copy it and ensure that we would have, the same positive results. So, there are stories coming out that the more vulnerable communities have not been sufficiently protected, that they are having, considerable morbidity and mortality in their older populations, particularly those in long-term residential care facilities. So I think the jury is still out a little bit as to how successful the strategy is, and certainly whether it can be applied anywhere else in the world.
This is more of a comment than a question that I do want to bring up from my colleague, Jamie Galbraith, who does a lot of work in China. And he says in China, there's a comprehensive supervision of public spaces to ensure that people are wearing PPE and that businesses observe the standards, as well as monitoring temperatures. Are we really planning to rely on individuals doing the right thing without monitoring or enforcement? So going back to, what is the role of monitoring, of testing, and then of the enforcement and the isolation? Have you gotten any sense if there is an idea of this type of monitoring process?
I don't know, and I do think that is more of a question for the folks in this audience, the people who understand this kind of policy. I mean, my sense is, for us not to be in sort of a dangerous position once we relax social distancing, entails that people really do adhere to recommendations, right? I mean, as your colleague mentioned, in Hong Kong, for example, temperatures are taken. If somebody goes into a restaurant, they write down their name, they write down their email address, so that if it turns out, and they're very closely tracking anyone who's potentially exposed, if it turns out somebody was infected, they can trace down that they were in this restaurant, they can call those people immediately. So there is so much kind of enforcement and surveillance, I think, happening, at least in in China, where we're hearing stories of successful suppression. Suppression is really like it's not that they're just trying not to exceed capacity, they're really trying to suppress transmission altogether. But I think it's, taking quite a heavy-handed approach that I don't know if, it would ever be palatable or legal here in the United States. And so then we're just relying on people's, decisions to comply for whatever reason. And so I think the next few weeks are going to be really telling as we do relax and we see what the consequences are in cities around the country. And it may be that different cities and different states, their behavior is going to look very different. And we're going to be monitoring the epidemiological data, the hospitalizations, whatever we can make sense of the case confirmed cases. But the other thing we're taking a look at is also the social mobility data, the sort of the cell phone GPS data. So the forecasting model that I mentioned in my talk, this is being driven by daily estimates of how much time people are spending at home and how frequently they're going to different points of interest in the public at a census tract level. So we're also going to be monitoring that. It won't necessarily tell us the epidemiological consequences of people spending less time at home, but it will give us a sense of the magnitude to which people are changing their behavior as we begin to relax some of these policies.
So Lauren, yesterday I saw on Vox that in looking at this geomobility data, that you can tell folks are getting antsy, that even before these stay-at-home orders have been allowed to lapse, that people are moving more. So I think that's interesting. We can have policies, whether or not people choose to abide by them is a different question. And perhaps culturally here in the United States, you know, there's an appetite for having that mobility.
Yeah.
I think I'm going to leave it there with questions. I do have one person who is working on COVID and wants to be reaching out because wants to join in with the team. I will get you that information. Again, I ask all of you to please check out our website. We will have all of the materials here with Dr. Ancel Meyers' research. And also I want to, I'm going to share my screen here to give you information on our next session. In the Arena goes live every Wednesday at noon, where we will be looking at the latest stimulus package with Ed DeCiv, who was President Obama's special advisor who oversaw the successful implementation of the 2009 recovery, in conversation with the LBJ School's own Martin Luby. Dr. Ancel Meyers, thank you so much.
You're welcome. Thank you all for being here today.
Bye-bye.
Bye-bye.